Hello friends, welcome to Wizac-Medical Concepts Simplified. In this video, we will learn about hyperkalemia, a clinical condition in which the plasma potassium is more than 5 millimoles per liter. Potassium is a very important intracellular cation with a normal value of 3.5 to 5 millimoles per liter, majority of which is stored inside the muscles. It plays a very important role in the generation of action potentials responsible for muscular contractions. Its regulation is done inside the body via dietary intake, whereas excretion is done primarily through kidneys and in some amount via stools. Depending upon the level of potassium, hyperkalemia is differentiated into three categories of mild hyperkalemia, that is serum potassium between 5 to 6.5 millimoles per liter, moderate hyperkalemia, that is serum potassium between 6.5 to 7.5 millimoles per liter, and severe hyperkalemia, that is serum potassium of more than 7.5 millimoles per liter. Hyperkalemia occurs either due to shift of potassium into extracellular fluid, or inadequate excretion of potassium through kidneys, or it may be pseudo-hyperkalemia. The extracellular shift of potassium may be present in the clinical conditions like metabolic acidosis, patients receiving hypertonic solutions like dextrose or mannitol, patients who are on digoxin, prolonged immobilization state, hyperkalemic periodic paralysis, rapid tumor lysis syndrome, osmotic hyperkalemia in diabetics, consumption of food which is rich in potassium, and red cell transfusion. The inadequate excretion of potassium may be associated with drugs like ACE inhibitors, angiotensin receptor blockers, spironolactone, eplerenone, NSAIDs, COX-2 inhibitors, beta blockers, and low molecular weight heparin. It may also be associated with clinical conditions like congestive heart failure, hypovolemia, systemic lupus erythematosus, sickle cell anemia, chronic kidney disease, and primary adrenal insufficiency. Pseudo-hyperkalemia may occur due to excessive muscle activity during venipuncture, that is clenching of fist, which causes efflux of potassium into the extracellular fluid, thus giving rise to false hyperkalemia. Symptoms of hyperkalemia are cardiac in origin. The primary effects of hyperkalemia is evident on cardiac muscles, giving rise to multiple arrhythmias including sinus bradycardia, ventricular tachycardia, ventricular fibrillation, sine wave pattern, and even asystole. Hyperkalemia initially decreases the resting membrane potential, making it less negative, thus giving rise to hyperexcitable state. This affects the repolarization phase of the cardiac action potential, causing changes in the T wave morphology, giving rise to tall pitch T waves in ECG along with the prolongation of PR interval and QRS complex. Severe hyperkalemia gives rise to loss of P waves along with the progressive prolongation of QRS complex and ultimately sine wave rhythm. Hyperkalemia causes depolarization of skeletal muscles, giving rise to hyperkalemic periodic paralysis. This may also give rise to diaphragmatic paralysis and respiratory failure. Some important investigations which may be helpful in diagnosing hyperkalemia and its causes include serum electrolyte level, which may show potassium of more than 5.5 millimoles, serum osmolality, which may be raised due to shift of potassium into extracellular fluid, urine potassium level, which may be less than 20 milliequivalents per liter, transtubular potassium gradient, which is used to differentiate hyperkalemia due to reduced tubular flow found in advanced kidney failure, from reduced potassium excretion found in conditions like drug-induced hyperkalemia or primary adrenal insufficiency. Apart from this, serum creatinine and BUN may show an increase in the value, which may reflect the kidney injury status. Before initiating treatment of hyperkalemia, serum potassium should be rechecked again to rule out pseudo-hyperkalemia. Drugs causing hyperkalemia should either be stopped or modified, and all the associated clinical conditions should be treated simultaneously. Treatment of hyperkalemia is divided into three stages of: first, steps to antagonize cardiac effects of hyperkalemia; second, steps to augment a redistribution of potassium into intracellular fluid; and third, steps helpful in removal of excess potassium. To antagonize the cardiac effects of hyperkalemia, intravenous calcium is used. As calcium raises the action potential threshold and reduces excitability without changing the resting membrane potential, it reduces the cardiac effects of hyperkalemia. The recommended dose is 10 ml of 10% calcium gluconate diluted in 10 to 20 ml of normal saline and infused intravenously slowly over 15 to 20 minutes with cardiac monitoring. Calcium gluconate should be used cautiously in patients who are on digoxin. In this case, it should be diluted with 100 ml of 5% dextrose and should be infused slowly over 30 minutes to avoid acute hypercalcemia. To augment redistribution of potassium into the intracellular fluid, 3 agents are used. First, insulin. Insulin lowers plasma potassium concentration by shifting potassium into the cells. The recommended dose is 10 units of human activated insulin mixed with 50 ml of 50% dextrose given over 15 to 20 minutes every 4 to 6 hourly. This may also result in hypoglycemia, and hence to avoid it, IV dextrose should be started simultaneously. In patients with hyperglycemia, insulin should not be mixed with dextrose and can be given as infusion or bolus. Nebulization with beta-2 agonist like albuterol or salbutamol should be given 4 to 6 hourly, as it helps to shift the potassium from ECF to ICF. As beta-2 agonist causes tachycardia, cardiac monitoring should be done, and it should be used with utmost care in underlying cardiac ailments. Sodium bicarbonate should be given intravenously every 4 to 6 hourly, as bicarbonate augments shift of potassium into skeletal muscle. However, it should be used cautiously, as it may cause sudden hypernatremia and increase the osmolality level. Finally, for removal of excess potassium, cation exchange resins like sodium polystyrene sulfonate or calcium polystyrene sulfonate, also known as K-bind sachet, should be used in a dose of 15 gram every 4 to 6 hourly. Apart from this, loop diuretics and thiazides should be used in hypervolumic patients. Finally, in patients with severe hyperkalemia, hemodialysis is the most effective method to reduce the potassium. So friends, this brings us to the end of this topic. Hope you find this information valuable and applicable in your clinical practice. Please do like and share this video and hit the bell icon for latest updates. Do check our Facebook and Instagram handles for more clinical insights, and for more such informational videos on medical topics, please subscribe YouTube channel Health Wizac Medical Concepts Simplified. Thank you.